All right. I think we'll get started here. Do you ever find yourself catch that voice in your head when you're working in the ED, sort of lying to yourself? That patient who came in, who has type 1 diabetes, came in with high blood sugar. You fix her sugar with IV fluids and insulin. Her sugar looks great. She's good to go. Discharge. Then another patient, a young woman who keeps coming back with asthma flares, right? She is unsheltered, sure. She might be exposed to cigarette smoking all the time. But I gave her Dionebs, prednisone, her lungs sound great, she's good to go, right? We fixed all the problems, so we discharged them. Deep down, we know, all of us know, the care that our patients really need is much more complex than that. But if you're like me, I check on our waiting list, and there are 70 patients waiting to be seen. And my training in the emergency medicine have taught me that at least a handful of them are hiding something that's life-threatening, and I can't miss that. I know that this patient with the glucose problem, what she really needs is a renewal of Medicaid application. That's going to take 3 hours getting connected to ED financial services. That other patient with shelter problem, what she really needs is to put her name on the housing application. She doesn't speak English. She's a recent immigrant. That's going to take hours. So what do I end up doing? I discharge this patient. This is the lie that I tell myself almost every time that I work in our emergency room. And I know that every single one of you sitting in this room resonate with me and with this story. We in the emergency department are drawn to this care with this idea that we are here to fix the life-threatening illness, heart attacks, pulmonary embolism, septic shocks. That's very, very true. We have to be really, really good at taking care of these patients. But we also know that majority of the patients that we see are coming in with non-emergent cases. And how good do we feel about the care that we provide for these patients? There's a vacuum in the space that we are working right now. Is it possible to think about socially responsive emergency care? My name is Haeyeon Hong. I am a current assistant professor and health equity fellow at Boston Medical Center. I'm also a health policy fellow at Commonwealth Fund. I am joined by my amazing team members, Dr. Naomi George from UNM, my residents, Nikki, Rachel, Alejandro, amazing people who really care about this issue. And of course, I'm so grateful to have our panelists on board here today, who I will give a thorough introduction later on. None of us have any disclosures. This is the setup of our didactics today. First 10 to 15 minutes, I'll be giving you a short, brief overview, and then followed by the expert panelist. And I want to make sure there's ample time to hear from you guys about the questions, the problems, and the barriers that you are experiencing in your own shops. Social drivers of health is no longer a new term. We know what this means. It represents the many different drivers of health that are non-clinical. I just wanted to highlight the recent addition to the definition CDC adapted from the earlier definition of WHO that includes forces and systems that include economic policies, development agendas, social norms, policies, racism, climate change. We have to think about social drivers of health in a broader context. During the didactics, we're going to think about why SDOH matter in healthcare system, and how does health policy influence the things that we see on our ground level in our emergency rooms? And why do we have to think about social drivers of health in emergency medicine? And what are some of the innovative ways we can think about addressing our patients' needs in our health system? Maybe a framework, maybe not. The last decades, there have been explosive amount of data that connects social drivers of health and our patients' health. Recent data suggests that when we compare the health outcomes of people who have high food insecurity compared to people who do not have food insecurity problems, patients with food insecurity have 10 percentage point higher hypertension, 15 percentage point higher chance of having chronic health problems. And you can imagine the connections that's been drawn with all different variables: transportation, housing, utility, you name it. And last few years with the COVID-19 pandemic, in addition to the importance of the social drivers of health to also the health outcomes, COVID pandemic really exposed the role that SDOH plays in creating health disparities. Turns out, people who are suffering socially, who are coming from socially vulnerable communities, people who are of color, are much likely to become sicker with the same disease pathology through social drivers of health. So much so that our federal government caught the importance of this. And as of this year, well, towards the end of last year and this year, the Biden administration really started to emphasize how important to think about social drivers of health in our health system. And they also published the US playbook to address social determinants of health. And the federal agencies then adapted this idea, created something called Healthy People 2030, trying to sort of come up with an innovative system that we can reimagine the way we can help our patients become safer and healthier with social drivers of health right in the center. Since 2015 or so, we have been using something called the Z code. You all know this. Z code is a subset of ICD-10 clinical modification code. And in some states, as of 2022, including Arkansas, Arizona, where we are in, Massachusetts, and Oregon, there have been state-level mandates through the Section 1115 Medicaid waiver to basically requiring health systems to start collecting the Z code. But honestly, how the Z code turns into financial gain for the health system has been pretty unclear. The reason it's important and timely to talk about this now is because earlier this year, in 2024 February, Center for Medicaid and Medicare Services announced that, okay, starting this year, for health systems that collect the social drivers of health data, we will start reimbursing you. Of course, this is a fee-for-service model. And this is probably why many of the institutions that you are currently working at are trying to figure out in your own shops how to do this social screening. Not easy task. I included this slide to say that it's not just a fee-for-service model. As you know, many health systems are moving towards alternative payment model, value-based care. Turns out it is incredibly important to factor into patients' social drivers of health when you adjust their risks, right? It's so much more expensive to take care for patients who are socially vulnerable compared to those who are not. So this is another reason you are seeing a sort of a national level emphasis on this data. Now, why SDOH in emergency medicine? This is a recent study published by Dr. Samuel Callow, thank you, based on a large cohort ACO patients in Massachusetts. About 35% of the patients who did not receive screening in the primary care setting end up showing into the emergency departments. Yet, right now, most of the health systems that are trying to do this new data collection are putting emphasis on primary care setting and inpatients. And it turns out the patients that we see in the emergency departments are much more socially vulnerable. Not a surprise to us, right? So based on this study, when you compare the patients who receive the social screening in the primary care clinic versus those who receive the screening in the emergency department, the percentage of people who screened positive for at least one social needs was about 7.8% in primary care clinic, whereas it was more than half, 51% in emergency department. This goes to show that the patients that we see in our ED day in, day out are different from those who are seen in the primary care doctors. These people are much more socially vulnerable. We know this, but now we have the data to show it. Yet, if you look at across nation, all different emergency department visit charts, only 1.17% of the ED documentations actually include Z codes. I do want to say this was based on 2016 to 19 data, so probably a little more than that. But the point here is that we are not capturing the majority of the data that we need to think about. Emergency medicine physicians have caught on this issue early on. And many of you sitting in this room have got together a few years ago via the form of consensus conference and started and galvanized this discussion. What kind of screening should we be thinking about in the emergency department if we're going to implement it? Our work environment is just crazy, right? So difficult to add any single screening question. What are some of the barriers? What are some of the things that we have to think about instrumental-wise? And what do we have to think about in terms of referral connections? When I'm thinking about what is missing in terms of SDOH in emergency department, I actually think that in terms of screening workflow development and implementation related conversation, that has already started to grow. I think the train has left the station. I think a lot of us sitting in this room are currently working on making this work. Not to say that we're there yet, but the energy is there, the focus is there. Something that I wanted to focus on here, though, is that this question of how can we leverage the social data to improve the care that we provide in the emergency department. Is socially responsive emergency care achievable? Recently, I was really inspired by this recent article published by Dr. Gottlieb in UCSF. And what her team did was trying to think about pathways through which social drivers of health impacts patients' outcome. As you can see, identify unmet social risks, and if those are addressed somehow, then these are different pathways, connecting social services, navigators, outpatient health services, tailored care plans. In thinking about sort of innovative ways we can fill in this vacuum that we talked about earlier, in efforts to reimagine socially responsive emergency care, we thought about sort of a bold idea out there. Can we, or should we, create a framework, sort of adapted from Dr. Gottlieb's article, that addresses different levels of social needs, that requires different sets of solutions? As we break down these problems in different levels, maybe, just maybe, we can lower the barriers that our patients and our providers are facing as they're thinking about how to really effectively address these things. So I'm going to stop here. You probably are wondering a lot of things. Is that going to work? There are different solutions. You might be feeling frustrated. I want you to keep all those thoughts and questions with you. I want to move on to our panelists for now. I am so grateful to have our three panelists join here. First, Dr. Maggie Samuels-Callow, who will be representing the research and innovation subject today. Dr. Samuels-Callow is an associate professor at Harvard Medical School, an attending physician in adult and pediatric EM at Mass General Hospital, and the vice chair for research in the Department of Emergency Medicine at Mass General Brigham. Her work focuses on developing interventions to reduce disparities in emergency care, designing strategies to use the ED visits to address adverse social determinants of health. Current NIH-funded projects include work to evaluate the role of individual or hospital factors to quality of care for children in general EDs and understanding how to best address unmet oral health and social needs in the ED. Our second panelist, Dr. Kimberly Stanford, who will be representing implementation. Dr. Stanford is an associate professor of medicine in the section of EM at the University of Chicago. She is the director of ED HIV STI testing at the Chicago Center for HIV Elimination and the director of ED social medicine team. She's an implementation scientist whose research focuses on interventions that leverage the ED visits to impact infectious and chronic diseases and social drivers of health. Lastly, Dr. Herbie Duber, representing the policy section. Dr. Duber is a professor of emergency medicine and section head of population health at the University of Washington. He also serves as the regional medical officer of Northwest Washington for the Washington State Department of Health. His work generally focuses on developing and evaluating health systems and health programs, ensuring access for vulnerable and underserved populations. So I wanted to start with Dr. Samuel Scalo, representing the research and innovation. Actually, let me give you this. Sure, Mike. Thank you. So Dr. Samuel Scalo, in what ways can we assess the effectiveness of social needs screening and referral programs? And after my presentation, any sort of thoughts that you wanted to share with us to begin with?
Yeah, so a couple of maybe quick thoughts. This could be its own didactic entirely, right? About how to think about the effectiveness of this type of implementation. But I think the first question is, what is the purpose of these programs, right? And so sometimes people are screening for social needs because they want to risk adjust their population for insurance purposes, or they want to argue for more programs to be in their ED or more resources from their state. But most of the time, when we're thinking about this kind of work in the emergency department, we're thinking about it from the perspective of an individual clinician or an individual clinical department that wants to do better by its patients, right? And so then we have to think about, is really screening in the sense of saying, how many days in the last 3 months have you been without food, the right answer? Or is actually the right answer to think about actually asking people about not just their social risk, but their social needs? Do you want help with food today? And so there's been a lot of work recently about trying to move the paradigm from one of pure screening to one about where we either expand the definition of screening from social risk to social needs, or think about the offering of something like a resource menu instead. Mel Molina's work, Danielle Cullen's work, there's been lots of work in this space, and I encourage you to think about, in the development of your own program, making sure that you're not just using, quote, validated screening tools, because there's been a lot of work showing that folks who are Black and Latinx are less likely to screen positive if you only use those tools, rather than asking people if they want help. So the first question is, what are you doing? And that's going to change how you design your program and how you think about the evaluation of the outcomes that you're aiming for. And that there's really a dearth of patient-reported and patient-derived outcomes in this space. We have generally fallen into the trap of saying, hey, we're smart doctors. We know what the right answer is for the outcomes. It should be people come to the ED less, or they connect to resources, or they do the thing that we told them to do. And those may be the right outcomes, but I would encourage you to think about that there may be other outcomes that are important to patients that we haven't yet ascertained, and there's a lot of room there for thinking about what the right outcome measures are, ultimately, that are both responsive to the needs of the healthcare system, but also responsive to the needs of the patient that we serve. Do you guys have anything you want to add in that space?
I'd probably add that when you talk about outcomes, I think that's a really important point, and we often focus, because that's what we do, on health outcomes, but those non-health outcomes, I think, are equally, and I would argue even more important. The idea of somebody who's food insecure becoming food secure, regardless of what it does to their healthcare utilization or the cost to the healthcare system, that's a good outcome in my mind. And so I think that it's worth thinking about this not just in terms of health, but also non-health outcomes.
And that, I think, is critically important if you're designing a program, because if you take someone from transportation insecure to transportation secure, they will use healthcare more, because now they can get to the doctor, at least in the short term. And if you have designed your program saying that your metric is going to be that you have reduced utilization, you are setting yourself up to fail. And in fact, you're failing your patients because you actually want them to come get the care that they need. And so we have to be really thoughtful about how we're designing these metrics to make sure that we're reaching what people actually need, but also not setting up metrics that are going to make our programs look like failure.
Thank you. Maybe we'll skip to the third and then we'll come back to the second because it's sort of related to the data. So in thinking about the barriers that a lot of these programs are facing, I think probably you're sort of getting to that as well, the systemic barriers and the data. What kind of data or evidence do you think will be necessary in helping us overcoming that barrier, in getting the buy-in from the department, from the health systems, in terms of letting us do this screening in a good way, right?
So I think some of that's going to be contextual in terms of what your individual institutions' barriers are going to be. And some of them are going to be based on how the health system is organized in your state. So I'll give you an example from Massachusetts. We are required to hit metrics for a certain percentage of our ACO population that has been screened for social determinants of health in order to get payments from the healthcare system. And so if we can make an argument that screening in the ED helps us hit those metrics, then great, that gives us some leverage with the healthcare system to be able to use that data to argue for increased resources in the ED. But ultimately, I think we're going to have to make an argument that's closer to what Herbie said, that what we're actually doing here is not just the screening, but the interventions that are downstream from the screening that actually improve health, right? And so we're going to have to make an argument and make it evidence-based to show that we can not only identify these needs, but address them in a way that actually improves people's health outcomes. And we have to be very careful that we're targeting our health outcomes and not only cost outcomes as we're designing these programs.
I would just add that although I agree with everything that you said, we have to remember who our audience is too. And we all are mostly probably in here because we're public health folks and we really care about the health outcomes, but the people who get to make the decisions are the people above me and above most of us, and they're the ones who care about the money. And so you kind of, I think, have to make your arguments in tandem. You have to show the health outcomes, but you also have to show the suits that you're gonna save them money over time, because if you can't do one, then they're not going to let you do the other. And so those things, I feel like, although we come at it from the standpoint of, I just want to make that health outcome better and I don't care about the cost of the system, other people who get to decide whether I'm allowed to do this intervention or not, they do care about the cost. And so if you can get that cost data at the same time as the health outcomes data, you're more likely to kind of get buy-in and support from the higher-ups in your administration overall to implement your intervention.
I think that's a really important point, but it also points to the type of data that you need, because you may not make a short-term impact on costs for the reasons we already talked about. And so you're going to need to think about a way to get longer-term data on this patient population, because you may not impact 7-day utilization with the types of interventions that we're talking about. And so cooperating with your local healthcare system, having state-level data, some way to collect longitudinal data on these folks so that you can show, because your cost impacts, if you're going to have them, are going to be in the longer term.
I agree with everything that both of you have said. I think that the challenge is that in the end, when I meet with the leadership of my hospital system, it always comes down to money. And they're like, we don't know if we're going to be able to operate with our current budget in a year or 2 years or a month. And so making these arguments becomes very, very challenging. A lot of people see it as the right thing to do, and I think that's important that our argument is centered in it being the right thing to do. But I have struggled personally in getting people to think about this from a long-term cost perspective, because we are, quite frankly, putting a Band-Aid on a very broken healthcare system where the financial incentives don't align, right? There is no financial incentive today to do screening. I hate to say this, but financial incentive to do screening when the goal for a hospital is around fee-for-service programs. It is just a messed up system. That being said, I think that's an area where all of us can advocate for a systematic change in order to better align those financial incentives. Sorry, that's very downer. I apologize.
Just one more questions on money. we often, receive this question of who will fund these initiatives type of questions. How has your hospital been funding the SDOH related initiatives, if any? And what are the pros and cons of grant versus institutional or state funded initiatives for this topic?
So for us, it's been a complete hodgepodge, and I would say that's definitely not the optimal way to do it, but it may be like the best that we get. So there's a little bit of state money that went into the ACO program that was originally used for some navigator support, and then that got pulled, partially because they had claimed that they were going to reduce short-term ED visits, and then it didn't work out as well as we had hoped. And then we use a lot of research dollars in this space, largely from NIH, like R01 and U-level grants to do this kind of work. And then there's a little bit of philanthropy support that supports some of it. And so it's like little bits and pieces. But there are opportunities, I would say, that we have missed to create more sustainable funding streams repeatedly. And so when you look at this CMS measure, or if you think about the new way that ED billing and coding charts came out, you get additional complexity points for talking about social determinants of health in your chart right now, but you don't get any additional points for addressing them. You can just say that it was a problem and keep moving, and you still get the complexity points. And if we had required that people like offer an intervention or do something about it, all of a sudden there would be money tied to doing that in a sustainable way, and that's not there. And so there are opportunities, like Herbie said, to think about advocating for a more sustainable funding stream in the long term, but in the meantime, most of us are just like piecing it together between a bunch of these kind of hodgepodge funding streams.
I'm going to move to the implementation. So Dr. Stanford, what are the different ways that community resource referrals or partnerships can be made from the emergency departments?
So that is a very complicated question, and I kind of struggled with where to even start with this. And I think one of the things that kind of struck me was like one way to think of it is like, are you referring people while they're in the ED, or are you trying to get to them afterwards? And also, like what Dr. Samuel said, is are you screening them, or are you noticing in your kind of organic conversations with them that there is a need that you're able to kind of identify, and then you're referring them directly to the services they need? And so I think there's kind of lots of ways of thinking about this. And I think there's no good one-size-fits-all solution as for many things. And so really it's kind of a combination. I have found sort of in my experience that reaching people after they leave the ED is very hard to do, which I'm sure all of you have also experienced. And so having resources embedded in the ED, I think, is the best way to get people face to face, get them connected to the resources that they need, and having somebody who can coordinate. So the other thing that we have done is we have either community health workers, or we sometimes will go through social work, and they will be sort of that point of contact for them, and then they will connect them to the other people either within the hospital or outside the hospital system who can help them with the resources that they need. So I think having kind of there's everything from having the nurses do screening, having an automated, sometimes, so one of the things we do is we actually pull lists of people that are coming in very frequently to the emergency department and go through their charts one by one to try to understand why they're coming in so frequently. I know there's folks working on AI programs to comb through charts and try to identify people with social needs that weren't identified otherwise. And so there's all these different ways of kind of identifying people sort of not passively, but kind of, not directly through talking with them. And then in addition, there's training folks who are working directly with patients to identify their needs and to try to have those conversations with them and to know what to do and how to refer them to the right resources that they need.
Oh, I was just going to say, if you are starting from scratch and you have nothing in your institution, which may be the case for some folks here, the United Way generally keeps a directory of social resources under a 211 umbrella that is national. And so if you have nothing else to start from a resource directory, that's often a place where you can start to create some of this information in your own system without having to individually find every food pantry in every neighborhood in your city.
All right. What are some of the implementation barriers as we are trying to think about how to tighten up the referral processes from the emergency department?
So I think we've kind of talked about some of this already. One of the big ones for us is not being able to contact people. So one of the things that we've run up against is we have this great system where we can put in an order for basically community health workers who will then reach out to patients after they've left the ED and try to connect them with services. And a large number of those people don't have working phones. Their phones have been disconnected. They've lost them, and we can't reach them. And so that's been a big barrier. And some of the ways that we have kind of addressed that, one way is by putting in a chart flag so that if they show up to the ED again and they don't necessarily identify that they have a need, it says, hey, please page the social worker when they show up to the ED. And so that gives the next team an opportunity to go and actually speak with them in person. The other thing that we did is there's, I didn't actually know this until a couple years ago, so I'm guessing some people in this room don't know it either. The government will give you a free phone if you qualify. And so what we did is we instituted this phone program, and we have somebody come to the hospital once a week at the same time every week. And if you want to get a phone, you just go over there and they'll fill out your application for you and hand you a phone. And we're working on having this so that they can actually come to the bedside at sometimes as well. And so that's been a way to say, you know, okay, if I can identify this need, then I give you a piece of paper. It says, show up at this time. We're going to get you, you know, we'll hand you a phone. And also, by the way, we can have our advocates talk to you about what other needs you have. Do you need a primary care doctor? Well, they can work on getting you that appointment, or how do we get you signed up for insurance? And we can kind of use that as an opportunity to get people signed up all at once. So taking that barrier and actually making it into an opportunity. And then really, aside from that, the other big one I would say is cost, which we've already talked about extensively.
So I think one of the challenges that we have as emergency physicians is that we're often, we like to follow a linear progression of things, right? Somebody's got septic shock, you go down this pathway. And I think one of the really important lessons that I've learned over time is that there is no one-size-fits-all pathway for this stuff. Every individual is going to be a bit different, and they probably fall into buckets, but we have a tendency to kind of create a linear pathway for folks when in reality there are probably multiple pathways that we need to think about creating and ways to move forward with an individual depending upon whether they have a phone, whether they don't have a phone, if they speak English, if they don't speak English. I think that there are just a lot of variables that we need to consider that we don't often do.
So we presented sort of a bold idea earlier, building a framework that could really lower the barrier of care that we hope to be able to provide one day. Do you think building a framework is useful in organizing our efforts to address social care in the ED? If not, anything else that comes to your mind? And I want to ask this question to the audience later too. Yeah.
I mean, I think being organized about things is always a good thing, and there's a lot of amazing work being done in this field. And so having a way to evaluate what we're doing, to standardize what we're doing, to share what we're doing, it's going to be different from place to place, but we're all facing kind of similar issues. So having something that's standardized to help us kind of share the work from place to place and share the lessons learned, I think definitely could be helpful.
Yeah, I would say, I think it's tempting. We come from a background in implementation science where like every other day somebody makes a new framework because they're excited about it, whatever. And like frameworks are awesome, but we can't just describe the problem. Like we've got to move beyond just making a better descriptive picture of what's going on here to thinking about how we're going to actually address it. And so if the framework is designed to like organize the interventional information and help us like move that dissemination needle, then great. If it's just another like, boy, these patients have a lot of social needs and they come to the ED a lot kind of picture, then I would argue that that may not be the most helpful way to move forward.
Thank you. Yeah.
So how do you guys address the fact that SDOH is like 10 different problems? If you can't address all of them, and different ones affect diseases in different ways. And so
So, I mean, I think there's what we think is important. There's what the patients think is important, first of all. And I think, you can only do what patients are interested in getting help with, right? So like an example I'm sure you all are familiar with is you've got an unhoused patient and you offer them shelter, but they don't want it. And so you can spend all your energy on that, but maybe you're going to waste your time and that's not what they want and it's not helpful for them. So I think having the resources for, knowing how to refer people to resources for what they want, what they think is most helpful to them. You start with that, and then you build on that. And you build on that by, in part by building relationship and building trust, so that they see that your team, your hospital, your social workers, those are people that they can go to and they can trust when they need something. And then hopefully you build from there.
So I think you can do that on an individual level, like Kim just said, but also on a community level. So we actually did qualitative interviews with folks in our ED to try and understand which social determinants of health were most salient to them, as well as with community resource providers to try and understand what were the domains that we ultimately should be trying to address within the ED. And it's probably no shock to you guys that like food, housing, transportation, and utilities won, right? Those are like pretty high priority things. Our healthcare system is screening for like education and employment and a whole bunch of other stuff, which are important, but we're sort of like less important than those kind of core four. So that's where we've like ended up focusing our efforts largely. And so you can think of it either on trying to match the individual's priority or trying to assess what the community priorities are within your area.
And I'm just going to add one more thing. I think it's easy for us to think that the conversation we're having is about putting more responsibility to the emergency medicine care providers. But what we're actually talking about is that we need to identify where the right resources are, where they exist, and how can we find that direct partnership and collaboration from our healthcare systems to the people who are there to do their job really well, so that when patients with septic shock comes in, our ED providers can really focus on those things, right? But to get there, we need to do this homework first by creating this solid pathway for our patients to walk through.
And I would just add to that it is putting some responsibility on us, but it's not necessarily that we're increasing the amount of work that we do or that we're the ones who are having to connect them to resources. Honestly, I think sometimes the hardest part of this is recognizing that they have a need in the first place. So even being aware that you need to be thinking about this, that you need to be asking people, because many people aren't going to tell you. They're not going to tell you that their phone doesn't work or that they don't have food to eat. And so you need to have that level of just, that awareness that you need to think about it, that you need to ask them about it, and know who to tell. If you have a social worker that works with you, you may not need to know all the resources that are available for that person, but if you can already take that first step of asking the person if they have food to eat or if they don't have a way to get to their appointments and say, great, I'm going to have you talk to the social worker, you've already made a huge, huge step in the right direction that's way beyond what most people are doing.
I think that's a good transition to the policy. Dr. Duver, how do we create a system that facilitates seamless communication and partnerships between healthcare systems and community-based organizations? What role should emergency medicine play in this partnership?
I don't think we can create seamless communication and partnerships, but I think there are ways that we can definitely improve communication and partnerships. I think that I generally will think about it as both the in-person and the technological solutions. So I think there's a lot to be said about creating real partnerships with community-based organizations in your area, understanding what services they provide, who they actually are reaching, what their outcomes actually look like. Are people getting the services that they are trying to provide? And then I think that there's also this technological piece that I think is really starting to grow in a lot of ways through these systems that connect healthcare EHRs to community-based organizations. There's a lot of work to do in this space, but it's been really exciting from my perspective to see the growth here with Epic's integration of Unite Us as an example of that, where you can actually integrate seamlessly. You can integrate the screening into the EHR and automatically send a referral to a community-based organization based on that individual's eligibility criteria and so on. So I think that there's a lot of opportunity there, and it's going to be really exciting as we start to develop that closed loop process, right, where the healthcare providers then better understand, were the services that that individual was seeking, were they actually met. As far as the role emergency medicine should play in this, ideally it's a tiny role. right? We're emergency physicians first. I'll be really honest, like the social workers know so much more about much of this stuff than I do. The community-based organizations and the people who work at those know so much more about this than I do. I know that the patients that I see have real needs, and their needs are not being met, and that is impacting their health and their non-health outcomes. And so I think that there's an opportunity to use this unique perch that we have in emergency medicine to advocate for that change. And that's where I think we can have the biggest impact.
What are some of the consequences, whether it's positive or negative, of the recent CMS policies related to social drivers of health initiatives that impact emergency medicine?
Yeah, so it's a really good question. And is everybody aware of like SDOH 1 and SDOH 2? It has to do with like, the first one is a MIPS measure that looks at screening for social needs, and the second is around referral. And it may actually be social risk, not social needs. So just, it's social risk. So it's one is, did you screen? And it's just a percentage. So right, it's, if you think about the Donabedian structure for quality, it's just the process piece, if people were screened or not. And then the second variable that they're looking at is the percent positive. Unfortunately, I think getting to what Maggie mentioned before, there's nothing about addressing them in the current measures. And I understand you got to start somewhere. And so I want to kind of give them the opportunity to move this forward. I just really hope that we do move forward from just, hey, we did it, to we did it and we're doing something with that information.
And what can emergency physicians in this room do to make that change happen?
Again, my career has moved a lot from being, an academic to much more of kind of state public health policy type work. And I think that we really carry a unique story and a unique voice. And so I'm just, more and more, I see that I can tell a story to a legislator. I met with a congressman the other day, and he seemed to think about it in a really different way after our conversation. It was around MOUD and stuff. But there's an opportunity to tell a story that we can tell that other folks can't.
I will say, a little bit biased from the research perspective, but you have the opportunity also to create the story, right? To create the evidence base of what is it that we should do once we find one of these needs, and figure out what the right strategy is for these different subgroups of patients. And then we have something to go back to CMS with and say, now we have an evidence-based practice that you should be measuring whether or not people are doing. Because part of the problem with arguing for intervention to be in the measure is that nobody knows what the right intervention is. And so it's much harder to make the argument that we should be doing that. You know, it's not like EKG for folks with chest pain where everybody can like sort of agree that that's probably a good idea. There's not like a similar evidence base in this space. And so you have the opportunity to create that evidence base and create the story.
That's true. And I mean, the only thing that I have to add to that is that I think sometimes we overestimate how much people who don't work in the ED understand the dynamic and the environment in the ED. People don't understand. I have similar interactions with like people that I'm talking to about some of the work that I do, and they don't understand why patients come to the ED for the things that they come for, and why do they come in the middle of the night, and like people just don't. And so part of our job is communicating that to people who are writing policy, and to health departments, and to all of these people who are going to make decisions that affect us and our patients. And they're making those decisions without understanding really like how it works in the ED and how our patients are affected by these things. And so that's a lot of what we can do, is communicate that so that the people making those decisions from higher up understand it better.
Thank you. We have a few minutes for questions. You can ask any of the questions. You can try to answer any of these questions that are relevant to your shop. Things you're doing in your shop that's working, not working out, questions you've wanted to ask your experts. I'm opening the questions to the floor. Yes, please.
Hello, I'm Lynn Richardson from Mount Sinai, New York City, and I'd like to thank the panelists and you both for the presentation and for the work. And connecting patients with social needs to community-based resources is very important. And there is a lot of progress going on. But whenever I'm in a conversation about this, I like to make the point that that is not the only responsibility we have in addressing these needs, that we need to think about how we can redesign healthcare to accommodate the social needs of our patients. And so perhaps some of you could comment on some promising or innovative healthcare redesign initiative that you're aware of that addresses some population of specific social needs, because we can't just, refer them to the emergency food pantry like that. That's not actually how to address food insecurity. And how can we help redesign the healthcare system to better accommodate patients' needs? Any best practices or promising programs you'd like to share? Of course you do, Meg.
Sorry. So I love that question because I think it challenges all of us to think a little bit like bigger and more broadly. And those interventions are harder to do, right? Because they require you to mobilize more people and more resources. And so just like 3 really quick examples. So my pediatrics colleagues, for example, have been leaders in this in a variety of different ways. So they have redesigned, bringing healthcare into schools, for example, to reduce transportation barriers, and school-based health centers that will see children who are enrolled in the schools and also any human who crosses their threshold, right? So all of a sudden, you've now brought a clinic to a place where a lot of people live near and are entering from. So you can see adults, you can see grandma, you can see anyone in that space. So that's critically important. And I will argue that many of those places are also providing like full spectrum healthcare, including like reproductive healthcare for adolescents and all sorts of stuff that's otherwise hard to access. So that's one example that I think is really promising. The other is thinking about how do you use your community benefit funds or money. Your hospital is a nonprofit. It's obligated to put money into community initiatives in some way. And often those are like varying degrees of hand wavy depending on where you are and how rigorously that's enforced. My colleagues from BMC have done an amazing job of using that to build housing in neighborhoods where people needed housing. So it's saying like we have money that exists in the healthcare system. We're not just going to say like we're sorry you're homeless, now you can be on the 8-year wait list for a housing voucher, but we're going to say here's an empty lot, we're going to build houses in this space and actually address the homelessness at that moment in time.
So I think we also need to be careful about the role of the healthcare system in addressing this. The reality is most of these problems are not healthcare problems. They manifest themselves with health outcomes, right? Or healthcare utilization. But let's be honest, like housing is not a primary healthcare problem. It is a societal problem, and we've chosen to deprioritize that. So I know that there's always this desire to kind of find the fix because that's who we are, like we're fixers. But I think that we need to think broader too. So I totally agree with you. There are ways that we can redesign the system to make it better, but the problem is not solved in healthcare, in my humble opinion.
Yeah, in the back.
I can just respond towards the poll. So I think we do have to be mindful of our responsibility around what is healthcare and what isn't healthcare. And I would respectfully disagree that if we're 1/5 of GDP in this country and if we truly want to impact health, I think we're learning that things like social determinants, prison care, and other things are key factors in how we influence the health of our communities across all communities. And as especially in emergency medicine, if we think about how we want to differentiate ourselves as we move forward, given what we've endured over the last couple of years, there are plenty of opportunities in this space and in many other spaces that we can lead because we are at the ground level of all that's wrong, not only in healthcare, but in society and how populations are marginalized and what we can do to impact it. I think our lens is particularly useful in that debate and in the solutions that we can present. So just a little bit of a pushback there, because I think that is the future, part of the future of healthcare, and I hope part of the future of emergency medicine.
Thank you. I think that's time. Thank you, everyone, for being here. if you are interested in continuing the conversation, further questions about anything that we discussed today, we plan to continue this discussion in a community matter. So please reach out. I would love to hear from you. Thank you.